Thank you, Dr. Indira Roy, ma'am, for your nice and brilliant presentation, as well as the current picture of use of semaglutide and its effect and side effects in Bangladesh perspective. And now it's my great pleasure to announce the name of our second speaker, Dr. Professor Iqbal Munir, sir, Chief of Endocrinology and Metabolism and Chair, Institutional Review Board, Riverside University Health System, and Clinical Professor, UCR School of Medicine, California, United States of America. And sir will talk about newer anti-obesity medications, a paradigm shift in obesity management. I would like to request sir to share his slides and start. Sir, do you hear me?
Slides. I shared already. I think someone need to project those slides. I shared in the Zoom already. Do you hear me?
Sir, your slides, we can see your slides, please. And we also, we can hear you. Please start your presentation, sir.
Wonderful. Good morning, everyone. Shobaike salam ebong shubhechha. I attended this meeting in person last year. This year I couldn't. I really enjoyed the meeting last year and I really wanted to go. And I remember you all, and thanks for this opportunity, giving me the stage to present on this topic. So my topic, again, will be very related to our previous speaker, who very eloquently presented this topic and also laid out several very interesting things in the perspective of Bangladesh, which I did not know. Give me a moment, I'm just, all right. Okay, so treating obesity. So if we need to treat obesity, we need to diagnose obesity like any other disease. And we also need to make an effort to understand what are the health consequences of obesity or the disease that we are talking about. So it very much asks you to do the quantitation of excess adipose tissue in the body, as well as identification of all the deleterious consequences of obesity on the individual. Now, if you think about it, we all have an idea about what is excess adipose tissue in the body for an individual, but there is no quantitative measurement actually. There is no good way to say this person has more obesity objectively than the other person, except you are just rely on the picture of the person or appearance of the person. Similarly, as you know, there are many number of conditions linked with obesity as a consequence of that problem. And that's neither precise nor very well studied also. So both of these criteria rely on imprecise measures. And as we heard earlier, that BMI is imperfect measure for adipose tissue mass. It overestimates adipose mass in muscular person. It underestimates in thinner person. So basically, this task has been given to a big practice group in the United States in 2024 to answer these two questions: how to quantify it adequately, and how to make decision that who need to be treated or not. So I think that's a very important step. So we'll wait for the recommendation of that committee. As I was told you, so if you look at the obesity, many conditions are associated with it, starting from mental, cardiovascular, coagulation, reproduction, pulmonary, malignancy, metabolic, whatnot. I even don't know how directly or indirectly everything is related, but we have a general sense many of these are linked with obesity. However, there is no debate about the metabolic consequences of obesity that we see, we feel, and we understand. So which is type 2 diabetes as a consequence of obesity, metabolic dysfunction associated with steatotic liver disease, hypercholesterolemia, chronic kidney disease, or atherosclerotic cardiovascular disease. All these are very easy to understand and to perceive that these are the consequences of obesity. So before we treat anything, the first question to ask is obesity a disease or just a risk factor? You know, there's a common belief obesity results from insufficient self-discipline. I think there's a little bit truth in it, but we over-exercise that notion. So there could be some truth, but there are a lot of false notions in saying that it's only a problem with the discipline. So we'll look into it. So the central argument that why it is a disease is the distinct pathophysiology. So what it does, as a result of that pathophysiology, which I'll touch upon, it leads to excess fat accumulation. So that's one step. But the second step is body serves to defend it. Body doesn't want to lose the fat. So coupled with homeostatic mechanisms that hinder weight loss and prompt further weight gain, it constitutes or behaves like a disease. So we tell that patients should be disciplined, they should make their effort to lose weight, and there was clinical trial looking at that. As you can see, there was an intervention group and there was a control group. So they were doing exercise, they are working very hard to lose weight. So to lose weight, and here, as you can see, the weight was lost, and they were diabetic patient, the hemoglobin A1C was improved. But majority of them ended up gaining the weight again. A significant amount of weight was gained. So they were able to lose, but they were not able to retain or keep the weight lost in that state. So something is working against them, right? Something is working against that process. And that's why it seems like a disease. For example, when there's a dietary weight loss, so all the gut hormones that we know and we use clinically for medicinal purpose, many of those are altered in a different direction, in a wrong direction. For example, we all know GLP-1 agonist. So what do you want? GLP-1, you don't want it to go down, right? But as a person is losing weight, GLP-1 level is going down. So similarly, if you see the other gut hormones, they are changing in a wrong direction. So that means they're fighting with the individual, and in a lot of cases that in that fight, the chemistry will win. So the person, even though they lost weight initially, end up gaining back lots of weight again. So again, the central argument is the distinct pathophysiology, which is related to obesity. So there's a gut-brain regulation of food intake. So the peripheral hormones integrate into central control of hemostatic and hedonic behavior. So it gives us satiety, it gives us pleasure, and we enjoy it. And that's why the principal target of the anti-obesity medication is different brain receptors, because, as we discussed, that is a gut-brain regulation. So that regulation need to be addressed, need to be targeted. My purpose is not to show explain these integrate mechanisms, but I just want to show these are the gut hormones, right? Like ghrelin, leptin, GLP-1, peptide Y, etc. all these are working in different gut receptors, as you can see. And when we are making anti-obesity medications, look, all the medication that we know, starting from liraglutide to tirzepatide to even medications like topiramate, naltrexone, all of them are binding certain important receptors in the brain, modulating the function there, and thereby you are getting the effect. So it's almost like a psychiatric medication the way we use. It's like that. So you already knew there are FDA-approved medications, and some of them are here, particularly the green ones. But I just want you to look at the mechanism, the broad categories. Some of them are adrenergic, some of them are anti-epileptic, anti-diabetic medications, and others. So basically most of them, except the orlistat, which is very straightforward, works in the gut level. The others, majority of them are working through nervous system or receptors in the brain. Now, patient came to you, patient want to lose weight, and definitely some patients are very eager to lose as much weight as possible. And then there are lots of weight loss medications these days, right? So what is the hierarchy? So at the top still, the sleeve gastrectomy. So sleeve gastrectomy will help losing 25% of the body weight. And then comes the newer medications. That the top of the medication list is tirzepatide, can lose up to 17–18%. That's the average. Some people will lose much more. Semaglutide, over 10%, so 12.5%. Again, this is average. Now, if you compare with other medicines, which is phentermine, liraglutide, naltrexone, bupropion, orlistat, etc., as you can see, the hierarchy. So these are gradually causing less and less weight loss. So now, let's talk about a patient who is a 46-year-old male. He has class 2 obesity, has history of hypertension, experienced a myocardial infarction 3 years ago. He does not have does not have diabetes. That's a very important one, and he wants for treatment. All of us are very familiar with aspirin, Plavix, statin, all these good medications, which certainly needed for this individual. But the patient is asking that, he wants to lose weight and he wants to see if weight loss is beneficial for the cardiovascular endpoint, right? So now, if these are the choices that we deal with, so I have liraglutide in hand, liraglutide 2.4, tirzepatide, orlistat, phentermine, topiramate. Which one will be appropriate for this person according to the knowledge that we know from the clinical trials? So you can think about it. All these are, at least a couple of them are very good options. First three are GLP-1 agonists. So let's look at some of the study and deal with that question. So incretins in weight management. So we know incretins in the diabetes management. That's many years, almost 10 plus years, those research are going on. But we are talking about incretins in weight management. So a very pivotal trial is SELECT trial. In the SELECT trial, this is an international double-blind study where they assessed the efficacy of semaglutide in patients with pre-existing cardiovascular disease, like our patient who had a history of MI, right? And happened to be having obesity like our patient. So they recruited the patients who are overweight or obese. It's a very large number of people, 17,000 patients, so 8,000 roughly in each end. And they were given semaglutide up to 2.4 milligrams. So this is one thing, in United States, we see patients frequently tolerate this kind of dose. I was very surprised to know that in Bangladesh, there are, of course, variation amongst the people. As I heard the lecture that, even with 1 milligram, lots of side effects develop. That's very interesting. So the cardiovascular endpoint, that was the primary endpoint of the study. They wanted to see if there's a cardiovascular death, non-fatal myocardial infarction, or stroke. So these are the endpoints. We call it composite endpoint. So that was the study. From that study, from the SELECT trial, so there are a lot of information that came from the SELECT trial. So let's first deal with the weight loss part before talking about the cardiovascular outcome. So as you see, the weight loss this is about 4.5 years after the patients maintained a weight loss. On average, the loss was more than 10%, 10 to 12%. But if you look at the individual groups, so there are people who are able to lose more than 20%. So you need to remember that fact that sleeve gastrectomy, that gives 25%. So even a small minority was able to lose more than 25% of the body weight. So there'll be always those kind of people who will respond to a drug very well. Others will not respond very much. But on average, 10 to 15% in that range weight loss with the semaglutide, 2.4 milligram in that trial. So yes, we say that it decreases the appetite. So basically all these medications, and that is true also for bariatric surgery, so they alters the gut, they alters our choices in the brain. So interestingly, when people are on this kind of medication, a lot of interesting choices they make. So it controls their craving. They feel positive. It controls the craving for savory food, controls the craving for sweet. So subconsciously, something is happening in their mind that is causing them to make better choices about food. Now, this is the study where, again, this is the SELECT trial. We are now looking at the cardiovascular endpoint. And again, remember, these are not diabetic patients, non-diabetic patients. I was part of this trial, so it was not easy because every other person with cardiovascular history, most of them has diabetes. So this group of people, as you can see at the end of the study, there's a wide separation. So about 20% risk reduction of the cardiovascular endpoints, composite endpoints. It decreased the incidence of death. So overall, it lowered the death rate in the semaglutide group compared to the placebo group. So that effect was about 15%. But overall cardiovascular risk reduction was 20%. So this is the only study I'm showing here, which is on the diabetic patient. Others are all on obesity, not non-diabetic. So in this study, they used 1 milligram. Again, this is not a SELECT trial. They used 1 milligram semaglutide, and they looked at the renal endpoint, kidney endpoint. And as you can see, semaglutide and placebo, the renal events were significantly less in the semaglutide group. So renal event means, the need for the prevention of kidney failure, loss of substantial kidney function, death from the kidney-related problems. So those events were significantly less. So this study was originally designed for 5 years, but as you see, this study was stopped 3.4 years after because during the interim analysis, the result was so obvious they didn't need to continue the study for 5 years. They stopped the study in 3.4 years, and overall there were 24% lower risk of kidney-related events in the semaglutide group, and that's with the 1 milligram. So overall, that SELECT trial is a very milestone trial for us to understand and act on. So if we summarize the findings from the SELECT trial, so which is semaglutide used dose at 2.4 milligram weekly, first, it decreased the atherothrombotic process. So that's why less cardiovascular events, whether this is directly by having some function at the vascular tissue level or other levels, we do not know. It caused durable weight reduction. So you saw that in the look-ahead trial that I showed. People lost weight with diet and exercise, but end up gaining weight. Here, up to 4 years or so, the patient remained, could maintain the weight they lost. So they didn't gain weight after losing. So that's very important. So it helps lowering the cardiovascular events, as we discussed already. It helps lowering the kidney-related events. Likely, most probably, helps with the heart failure outcomes. That's not very sure. We need to do further. We need to look at further data. And definitely, it's going to lower the development of type 2 diabetes. Overall, that gives improved quality of life. So that's the practical implication for the SELECT trial. Now, the case that we are talking about, so clearly, even though there are 3 GLP-1 agonists at the top, the choice will be semaglutide because that's the only one which had been studied for a patient like this person who is obese, has history of myocardial infarction, and does not have type 2 diabetes. Now, how long to continue weight loss medication? So we asked this question. That's a very good question. And when you ask that question to the weight loss specialist and the scientist, they will ask you a second question and third question. They will ask you, how long do you take medications for diabetes? They will ask you how long you take medications for hypertension and hyperlipidemia. I think this is very important because we don't question to give diabetic patients anti-glycemic medications years after years. So does hypertension and hyperlipidemia. But we always, try to find out that how long to give the medication for the obese patients. Now, these are 2 very important trials to look at for another very important thing. So in this study, so semaglutide, the patients were getting semaglutide, all of them, they lost weight. And what they did, they put one group, continued with semaglutide, other group, they switched to placebo. So what was the result? All the people who were getting semaglutide and losing weight, when they were changed to placebo, they started gaining weight. So this is another trial, SURMOUNT-4 trial. That's the similar kind of study with tirzepatide. Again, same thing, tirzepatide caused the weight loss. And then people who took tirzepatide, their weight loss continued, but who stopped and just took the placebo, they started gaining weight. So the answer to that question, how long to take, is again the same question. How long do you take in diabetes? How long do you take for hypertension? That means it's indefinite duration. And that need to be discussed with the patient before you start the medication. We try to find weight loss plus effects, right? So whether it is a cardiovascular outcome, whether it's a renal outcome, improvement of lipids, improvement of blood pressure, and all of them are shown to be by semaglutide. Resolution of NASH, that's also there are some data with semaglutide, but there's excellent data with tirzepatide. As you can see, the NASH or MASH, so metabolic defect associated steatohepatitis. So placebo, and these are the different doses of tirzepatide. There are just substantial resolution, substantial number of patients. If you compare with the placebo, you can see clearly when they were receiving tirzepatide, their MASH resolved. MASH, NASH, sort of similar thing, MASH resolved. And in this case, they were looking at the fibrosis score. There was some improvement of the fibrosis. That this data was not very strong, but this data was pretty good. So these drugs, these obesity drugs, as you know, NASH, MASH, these are the results of obesity, and these medications are helping to resolve those or help those issues. So I know that the time is already, I've spoken 22 minutes. Give me another 3 minutes and I'll try to wrap up. So what does the future of medical management of obesity look like? So that's the question. So that at the backbone, there is GLP-1 agonist. Now we started combining many other molecules with this GLP-1 to develop twin incretin or so biagonist, triagonist, all this drug. For example, we are familiar with tirzepatide, which is GLP-1 and GIP-1. So retatrutide is GLP-1 and GLP-1, GIP, and glucagon agonist. This is not FDA approved yet, but fantastic performance in the clinical studies. GLP-1 and glucagon agonist, which is survodutide. So that's another very interesting agent. We can add amylin agonist, so GLP-1 plus amylin agonist, like the cagrilintide, the drug which is in the clinical trial, and peptide Y agonist plus GLP-1, so that's another combination. So just quickly, oral semaglutide, that's in stage 3 trial, clinical trial. This is the 50 milligram dose, which will be coming in the market, it's not FDA approved yet, but as you can see with the pill, people are losing up to 17% or more. Tirzepatide, already you know, more than 20%. And similarly, there are other medications. The remarkable one here, retatrutide, this is the triagonist, GIP, GLP, and glucagon. See, 24% weight loss. It's very good. So just briefly, we want to use the properties of these different incretin molecules, GIP, GLP, glucagon, amylin, peptide Y. I want to just point out one thing that we don't talk that much. So we all talk about appetite reduction, but another way of losing weight is increasing the energy expenditure. So these three molecules, amylin, peptide Y, and glucagon, all three they cause increase in energy expenditure. That's why the combination of some of this molecule will probably help lowering weight further than what we are currently seeing with the GLP-1 agonist and the combinations. So in conclusion, obesity is a chronic disease. We know the FDA-approved medications. We heard about semaglutide 2.4 milligram. We heard about the SELECT trial where there's a cardiovascular event reduction by 20%. We know about tirzepatide, which is phenomenal in weight reduction. If a patient fails one GLP-1 agonist or weight loss medication, a different one should be tried. So as you know, all patients will not respond to one medication that you like, whatever that medication, right? So you can change to another one. And then the issue of combining. So if we can combine different diabetic medicine, different antibiotics, there should be a room for combining different anti-obesity medications to give the optimum effect. Maybe smaller dose of two different medicines will lower the side effect. So we need to understand what is the optimum combination. Some people do it, and we just need to understand a little bit more, but people already do that combination. Treatment duration is very important, long-term or indefinite. And there are several GLP-1 agonists in the pipeline with various combinations with other incretin molecules. And who knows, if we can develop GLP-1 agonists or medications instead of once a week to once a month, then after losing weight, we'll be able to maintain weight with a medication which someone need to be taking once a month or so. So something will come up in the future. Everybody is thinking about it, but it's not here yet. So with that, I'll stop here. Thank you very much. Thanks again for giving me the opportunity to present in this meeting.